It doesn't affect everybody the same. So the vast majority of strokes are ischemic. And what the term ischemic means, and this may be very obvious to some people, is that there is a oxygen supply-demand mismatch. So there is not enough oxygen getting to where it needs to go for the brain tissue to feel fine. Ischemia happens all over the body. It happens in the heart, that's a heart attack, or angina, that's the symptom of ischemia. Happens in the legs. Claudication is the name for ischemia in the legs when it's related to an oxygen supply-demand mismatch. And the reason this happens is because, and we'll get into this, but there's just a limitation in blood flow for some reason. So that's the vast majority. 80-90% are ischemic. And we'll go over what the other one is. And then there's also major regional variation. So not only are there sex and race variations, but there's major regional differences. So, this should go a little bit slower, but over here, this is just stroke. This is stroke death rate. You could do this for stroke number, stroke hospitalization. They all kind of look the same. And we've all probably heard the term stroke belt. Nod your head if you've heard the term stroke belt. So the South is known as the stroke belt. And you can see why, okay? The stroke belt is actually moving a little bit. So these increased incidents up into the upper Midwest is actually a fairly new phenomenon. For decades, it was primarily located in the Deep South. Mississippi, Louisiana, all the way over to Georgia, up into South Carolina, a little bit in southern Tennessee. And the reason why is this is where a lot of other problems happen. So we call it the stroke belt, but it might as well be the hypertension belt, the high cholesterol belt, and it's also, I did most of my research, I didn't say this, was in disparities in healthcare and disparities in disease. And so this is also, if you look at, so the first one, so this is population living in poverty. So these, if you sort of superimpose these maps on top of each other, they look almost identical. They're not going to be identical, but they look very, very similar. So these are diseases of not just I have high blood pressure, it's diseases of I don't have access to a healthcare provider, I don't have access to medicines, I don't have access to the things that I need to be healthy. I have a bad diet, I don't have enough money to buy good food for myself. These are not easy situations to unpack, but they tend to fall all within the same realm, and they're all kind of concentrated right where we live. Interestingly, although you may not, you don't really appreciate it here, this is the stroke death rate, but the stroke prevalence and incidence is actually a little bit lower in the Atlanta metro area, and you can kind of see probably why. So the area living in poverty is actually a little bit lighter in this area, and that actually tracks with some of the, I can't go backwards, but maybe we can figure out a way to give them access to this PowerPoint after, and you can just click around with it if you want. But these are all freely available on CDC. If you just type CDC hypertension, CDC stroke, CDC heart attack, you can get these beautiful maps and kind of see more about it. I think it really helps with understanding the impact. All right, so these are those two causes of stroke. So ischemia. The most common reason why people have ischemia is cholesterol buildup. So cholesterol buildup, typically in the neck. Now this can do one of two things. Either the buildup in the neck, stenosis, or narrowing of the arteries in the neck that take blood flow from the heart up to the brain. It gets so narrow that you then develop symptoms or have a stroke. Okay? That's actually less common than these cholesterol plaques in the arteries breaking off little pieces, and then they embolize. They follow like a lazy river. They follow the blood flow up until they get to a smaller blood vessel where they can't go any further, and then they stick. So then you have no blood flow past it, and then that area is not getting blood. What is blood carrying? Oxygen. So that area of brain tissue is not getting oxygen. Now, sometimes that doesn't even matter, really. Sometimes it blocks and then does something called recannulize, meaning it just kind of goes away. The blockage dissolves quickly, it goes away, the vessel opens back up. That's often what happens, we think, when people have what's called a TIA, a transient ischemic attack, or a mini stroke. That's what people have, but it's not really a stroke, because a stroke, the term stroke means there's been damage to the brain. And long term, how you do with a stroke kind of just depends on a lot of things, but the brain is pretty plastic, it's pretty resilient, and so a lot of people who do have ischemia and loss of blood flow and damage to the brain can then recover function, because the brain either learns to do those same things where that brain tissue didn't do well, they learn from other parts of the brain how to do it, or that area gets better. But that's ischemia. There are other causes, so it's not just the neck. How many people have heard of atrial fibrillation, AFib? So that's an irregular, that's something I deal with literally every day this morning. It is an irregular heart rhythm. So instead of, ba-bum, 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 just a nice regular heartbeat, it is all over the place. It's irregular. Blood doesn't like irregularity. Blood likes regular pulsatility. When blood gets irregular and moves irregularly, it slows down. And when blood slows down, it forms a clot. If you've ever cut yourself and you had a clot form or scraped your knee, as the blood slows out of the blood vessel areas and sort of just sits, it forms a clot. And that's good when it's on the knee or on the arm and you need to fix a cut. It's not good when it's happening in your heart, because that heart is going to pump clot potentially up to your brain and cause a stroke. So that's why we put people with AFib on blood thinners. Yeah.
You mentioned earlier about cholesterol going up to the brain and blocking the flow. Would that be a big cause with Alzheimer's?
That area of research is active. So we definitely know that dementia,
Or dementia?
not necessarily Alzheimer's, but dementia, there's a specific kind of dementia. Again, I'm not a neurologist, so they may, hit me for saying words like that I don't really know are still being used, but vascular dementia is a very common reason for dementia, and that is multiple, it doesn't even have to be big strokes. It doesn't even have to be strokes, period. It can just be micro, small, imperceptible limitations in blood flow to areas of the brain over periods of time, and we see this on MRI when we do them. We see areas of microvascular disease, very small, imperceptible to you. You're not going to have the symptoms that we talk about for a big stroke. But over time, and these are due to high uncontrolled blood pressure over decades, uncontrolled cholesterol, smoking, again, things that we're going to get into, but that is very clearly a reason for dementia. So when we talk about things that we do to reduce your risk of stroke, they also use terms like it's for brain health. And the reason it's for brain health is not because you've avoided a stroke, but you've also avoided these micro insults to your brain over years and years that then eventually cause dementia. That's a great question.
If you're taking steps to bring your cholesterol down,
Yeah.
I assume that it's not because it's breaking off. And how does the body eliminate that cholesterol?
It's a great question.
What's the question?
So how do things like, I'm going to interpret your question to mean medicines, but it can mean lifestyle changes too. Taking medicines for cholesterol lowering, statins, how does that get rid of these problems? And through a variety of methods. I like to use an analogy to, if you drive anywhere on the roads in Atlanta, you see these metal plates all over the place with potholes, okay? So your car doesn't explode when it hits one of the potholes. So I think of statins and medicines like that as almost like putting a metal plate over that pothole. Most of the time it doesn't make the problem go away completely, but it prevents the major adverse outcome from happening, okay? And allows things to go on generally as normal, okay? You may curse when you go over it, but you didn't end up, ruining your car by hitting a pothole. So the statins work in a number of ways. They lower cholesterol so that you're less likely to build up plaque on the walls of the arteries. They also do what's called stabilization of plaque. So it gets very, very challenging and very confusing very quickly, but all cholesterol buildup on the arteries is not created equal. So some are more susceptible to activity. We call it rupture, plaque rupture, and that's what causes things like major heart attacks. So you can have a small blockage, small buildup, a buildup that's only taking maybe this much of the artery. But if that thing ruptures, if it becomes unstable and leaks out a bunch of the inflammatory pieces that are within that plaque, then your body's natural response to foreign objects goes and forms a major white blood cell attack in that area and clogs up the whole thing. And that's what causes a major heart attack. It's usually not that the artery gets more narrow and narrow and narrow over time until you get symptoms. That can happen, like I mentioned before, but that's not usually what causes the big, sudden, acute problem.
Well, if you haven't taken any medicines and all you've done is lose weight, change your perhaps diet, but then where is that cholesterol going when it comes from 280 down to
It's just being packaged differently. So it's going from being packaged in a way that causes it to be bad and to sit on the vessel wall and to be inflammatory and to potentially be unstable to being more stable or processed out of the blood completely through the liver. These are all really good questions. Statins do more than just lower your cholesterol. They have anti-inflammatory properties, and they also stabilize plaque. So they help make vulnerable plaque that seems more likely to cause a problem. It tends to stabilize it and put a better cap essentially over that cholesterol area. AFib can cause the same thing, but it's a totally different process. Okay. The other cause that's much less common is hemorrhagic. Okay. This is typically very, very, very high blood pressure, or if you already had an aneurysm for any number of reasons, random genetic mutation or a known family genetic mutation. If you had an aneurysm, you might get it spontaneously, okay? Sometimes the aneurysms are large enough, and again, neurosurgeons and neurologists would be the better people to ask, but if aneurysms get big enough, we even consider going and doing brain surgery to clip them and make them less likely to rupture like this. Most of the time, in people who don't have those problems, this is caused by long-standing uncontrolled high blood pressure, or major fast spikes in blood pressure, having normal blood pressure and then taking something like cocaine and spiking your blood pressure super, super, super high really quickly, amphetamine super, super quickly. That's what can cause this. This is usually more common in younger patients who either don't know that they have a diagnosis of hypertension already, or they have some inherited aneurysm disease that they don't know about, and that's how we find out, unfortunately. But this is much less common. All right, so everyone kind of, I think, probably knows the symptoms of stroke at this point, but there are a lot of acronyms that we use, and the most common one is FAST, all right? So these are, if you notice somebody having these symptoms, these are what you're looking for, but also what you can ask them to do to try to get more information. So first is facial weakness. I think we've probably all seen the picture of somebody trying to smile and one side coming up and the other side looks like it's going down. Often it doesn't even do anything, it just stays there, but it almost looks like it's drooping. So, you would, if that looks like it, ask the person to smile. When you smile, you sort of engage almost all of the upper cranial nerves, and those are frequently involved in the majority. Those are involved in the majority of strokes. Not every stroke, but in the majority of strokes. So the yield for these questions are high. That's why we don't ask all the questions about balance and everything. So you ask them to smile. I'll just let that all go. So arm weakness, numbness some, but it's really weakness. So you basically ask them to lift their arms up, and you'll either see, one can't come up, or you'll see a drift like this, and they can't keep it up. So they should be able, if you ask them to lift their arms up, they should be able to do it like this, or all the way up above their head as well. If speech is altered, so we all think about slurred speech, but it's not just slurred speech, it's nonsensical, or an inability to respond correctly. One thing that I would do when I would see patients in the ER and wonder if they had a stroke, I'd ask them, what day it is, but then ask them to name the days of the week in order from the day. So Tuesday, Wednesday, Thursday, Friday, Saturday. And if they have trouble doing that, either they put them in the wrong order or they just can't get the words out. That's very concerning. What is your name? And then also asking them to just say a simple phrase, the sky is blue. Something easy that they should be able to repeat back to you with no problem. If they have trouble doing that, that's a very big concern. And then time. The last one is time. So facial weakness, arm weakness, speech alteration, and then time. The reason time is so important is as soon as you think somebody's having a stroke, the most important thing is that they get to a hospital and get evaluated. The mantra, the old mantra, is time is tissue. Okay, so that brain, we talked about ischemia, there's a lack of blood flow getting to where it needs to get in the brain. If we relieve that obstruction and open it up early, the likelihood that we save that tissue is much higher. And that's why we always, if you get to a hospital, if you've ever been with somebody who's had a stroke, or, if you get to the ER, the first question they're going to ask you is, when was the person last normal? Do you know when the person, when did this start, basically? Because that really helps decide what the treatment pathway is going to be. Because if this started an hour ago, we're going full bore, opening up that vessel, either doing intervention where we go up and try to get the clot out interventionally, or use blood thinners or something. But if it happened 24 hours ago, or nobody knows and it's unclear, it becomes a lot less clear on what to do. The interventions that we do to relieve stroke have risks, right? Pumping somebody with a very potent blood thinner is risky. Going in and doing a procedure where we go up with catheters and wires up to the arteries in the neck and into the skull is dangerous. It's important to do in certain situations, but they carry risks. So we don't want to do something that may not have a benefit if it also has a risk. And that's kind of true of everything.
What does a stroke look like when it's in progress, or is that something you're not like?
This.
It
Yeah.
looks like that.
Almost always. There are other symptoms.
So that happens immediately as the stroke?
Early. These are early symptoms of stroke. Oh, hold on. We were doing so well for a second. So, yes, these are early signs. These are early signs. Now, sometimes you may have those symptoms resolved by the time the ambulance gets here, right? We talked about TIAs, right? Transient ischemic attack. These are symptoms of ischemia. The brain's not getting enough oxygen. It doesn't matter. You call 911 once this happens. If the patient is normal by the time the ambulance gets there, typically they will still bring the patient to the ER so we can do some brain imaging, make sure it's not a stuttering event. So happens, symptoms go away. Happens, symptoms go away. That's still very concerning and still may require treatment. Maybe you get symptoms, they go away, you get to the ER, you never have symptoms again. There are risk calculators, but even a TIA has a relatively high risk that a true stroke will happen in the future, within the first 30 days especially. So it's important to get seen, evaluated, and to be put on medicines if you're not already on them, okay? So yeah, that's the FAST. This is from Duke University. They include like balance loss and eyesight changes. I usually don't focus on those because balance issues and eyesight issues can happen for a lot of reasons, but stroke is one of them as well, especially when you get one eye affected. So if you like all of a sudden lose vision in one eye, painless vision loss, that can be a problem. But that can also obviously be due to other eye problems. So that's why I don't usually include those. There's usually something else going on, these other things that are a little bit more what we would call sensitive for stroke, meaning that if they're not happening, it's unlikely that you're having stroke. So what I would say is if you had some balance issues or eyesight changes, but none of these other things, it's a little bit less concerning for stroke. Still let somebody know about it, maybe call your primary care doctor, cardiologist, somebody, but I think it's less important that you're calling 911 right away. Yes?
I have a unique situation. I have panic attacks that take the form of TIAs. So my mode of attack is, if I'm by myself, number one, go where there's somebody, tell them what's happening, and tell them to distract me, to talk to me for 5 minutes.
Yeah. So
And
which
usually,
of these?
if it goes away
Yeah.
within that 5, then I don't drive for the rest of the day. I stay around people.
Yeah.
But
Which of these things?
it starts with numbness on the left side
Okay.
of my face.
Okay.
That's when I
Yep.
tell somebody.
Have you ever tried to do the smile and see if there's weakness involved also?
Sometimes it depends before I realized what it
Yeah.
was, it would progress to
Yeah.
that, yes.
Okay.
Now it does not.
Yeah.
Though I have to check it.
I would say, so you're right, other things can cause all of these problems, right? But the constellation of all three is very specific for stroke. If you are having numbness, facial numbness, tingling, things like that, very common with panic, anxiety. You should not, again, everybody is different. Most of the time, weakness is not part of that. So you should still, most of the time, be able to have a symmetric smile despite having numbness in one area, okay? Again, everybody is unique. This is not meant to be like it's gonna capture 100% of strokes, but these are the big high risk features of stroke that you should really be aware of. What else? What other questions? Yeah.
If you're in the middle of nowhere, is there anything that you can do, any medication you can carry with you, like an aspirin?
Yeah,
or
baby.
whatever?
Yeah. Most of the time when people hit the door, they're given a full dose aspirin, 325. I'll be honest, I know much more about the data behind that for heart attack as opposed to stroke. So I can't tell you whether getting that 325 of aspirin as soon as your stroke symptom starts is associated with any improved outcome. I honestly, I don't know that. That's an interesting question that I can look up. Hope that you have good cell service and call and text. I don't know. There's being out in the middle. This is a problem. During COVID, like a lot of things, during COVID, the statistics suggest that stroke went down. It obviously didn't. It's just people didn't go to the hospital for it. So they were having strokes at home and not getting seen. And now probably what we're seeing longer term, that's why there's a big jump in the prevalence of stroke currently, because we missed a lot of stroke for 2 or 3 years. There's not a good hopefully you're with somebody and they can get you to the nearest medical facility or call. But if you're by yourself, I'd say maybe some aspirin, and that's probably it. Yeah.
If you felt like you're having a stroke or someone in your family and you call and the ambulance comes, is there something that they give you right away, like to stop a heart attack, where they put it right into you on the truck?
No. I think there are some trials in very remote areas for the ambulance drivers to carry something called TPA, which is the like big, huge clot buster that they'll give you if you are having a stroke, but it's very risky.
Yes.
You need to have the right blood pressure. You can't be on certain medicines. And then, it's a lot, there's a huge questionnaire that neurologists and ICU doctors and the ER doctors go through with the patients or the family if the patient can't do it, to try to figure out if the patient is appropriate for TPA. Because you could do a lot more damage to somebody by giving them an inappropriate medication that they don't need than by just getting them to where they need to go quickly. So there is no like in the ambulance treatment for stroke.
Okay, they just rush you there.
They get you to wherever you need to go as quickly as possible.
I know somebody in my family that we insisted that she come to Emory. I hate to say this, but I have another hospital that's closer, and I said, no, take her to Emory immediately. And they took her in right away, and they did give her something immediately. What did they give her?
TPA probably.
Okay.
Tissue plasminogen
I'm
activator.
familiar with what it
Yeah.
is.
It was probably TPA.
And she's fine.
Yeah.
Okay.
She does take really high doses of, I think, statin all the time, and she wants to not take them, but they said, no, you're going to just keep taking them.
That's
So
what I
now we
say.
know why.
All right. So this is, I can't remember if I got this from CDC or somewhere else, but it's just like a 1.5 minute where it actually has visuals that go along with these things, not just word. If you Google fast stroke video, this sort of stuff will come up, okay? The American Heart Association Stroke Division has them, CDC has them, National Heart and Blood Lung Institute, NHLBI has them, everywhere has them. Probably Emory has one, I just didn't look up Emory. But we're not gonna be able to, I don't think it's gonna play. Yeah. So the last thing, I kind of went much more than just signs and symptoms of stroke because there's only a couple that we're gonna really talk about. But, prevention of stroke is kind of the biggest thing, right? We want to prevent a stroke. And the things that you do to prevent a stroke and to promote brain health in general are the same things that you do to prevent heart disease and the same thing that you do to, work on blood pressure. And, this is an infographic from the Stroke Association, AHA. But the AHA also has this thing called the Life's Essential 8. Okay, these are kind of 8 targets that they have identified that in trial after trial, not even trial, sorry, observational study after observational study, the people who do the best in these 8 buckets have the lowest rates of heart attack and heart disease, stroke, vascular disease in the legs. So sleep is actually the newest one that was just added. And as somebody who has a 2-year-old and a 6-year-old, I find that kind of offensive that they have sleep in there. But 7 to 9 hours, I would love. That would be great. 7 to 9 hours of sleep each night. So the diet, people always ask, like, what should I be eating? It's a hard question. There's a lot of non-medical things that go into what you can eat and what you do eat. Okay, cultural, financial, there's just a lot that goes into it. Generally, when they say eat better, I love that, eat better. That's why I put it in quotes, just eat better. Generally, that means diets as high as possible in fresh foods, non-packaged, non-processed. We all use things out of boxes and cans and stuff like that, and that is fine. Those tend to come packaged with higher degrees of sodium, which is salt, which will increase your blood pressure, worsen your vascular health. Highly processed foods have a lot of trans fat in them, which is the worst kind of fat. Fat is not bad. There's a lot of really good fat. Polyunsaturated fats, like the fats that are in fatty fish, for example, or fish oils, those are good. Those are really good for you. They're anti-inflammatory. They promote lower bad cholesterol, better good cholesterol. These are expensive foods. They just are. Like that, there's no way to get around it. Like, to eat healthy is expensive. The unsalted fresh or unsalted dry nuts. I mean, my wife has an anaphylactic allergy to nuts, so we don't eat them. But I will pass them by. It's like $15 for like this much nuts, right? Like, it's hard. It's very, very hard to eat healthy. I tell people most of the time, just try to find areas where you can make small gains, right? If you are eating fast food 3 times a week, make it 2 times a month or 3 times a month. People don't like vegetables, try different ways of cooking them, or, put them into a smoothie somehow just figure out other ways to get these things into your diet. But diet is by far the hardest one, I think, of all of these things. Exercise 2.5 hours of moderate or 75 minutes of vigorous activity per week. The way I talk about it is 30 minutes a day of moderate activity 5 days a week. If you can do that, you're hitting your goal for heart health. And the really interesting data that's come out is there are huge gains from being basically sedentary to getting up to this level. But if you decide, hey, I want 30 minutes 5 days a week is good, an hour 7 days a week must be great. The benefit change to that is very minimal. So you actually don't get much more benefit once you do moderate activity. Moderate activity means you can carry on a conversation, but you're a little short of breath doing it. So you can still talk. It's not like you can't talk because you're breathing so fast and so hard and so focused on what you're doing. I'm walking quick enough to be a little bit short of breath, but I can have a conversation with somebody. 30 minutes, 5 days a week. That is the sweet spot for vascular and heart health. You're not going to lose weight doing that, okay? Most of us aren't going to lose weight exercising because we're not Olympic athletes and doing like 6 hours of high intensity training every single day. Unfortunately, most of our weight loss has to come from calorie restriction, and that's just what it is. Yeah.
I've always been under the impression that exercising, being active, is one way to get rid of cholesterol.
It will lower bad cholesterol, and specifically most of the benefit comes from increasing HDL, which is the good cholesterol. Okay, so that is where most of the cholesterol benefit from activity comes from. Yep. You don't want to have diabetes. Diabetes is bad. If you have diabetes, controlling it well with medications is really important. Again, appropriate weight, so BMI being around 25. BMI is an imperfect measure for these sorts of things, but having not being extremely overweight is obviously very beneficial for all of these other things: cholesterol, sugar control, blood pressure. Blood pressure is an interesting one. The lowest blood pressure that you can have and tolerate is the best thing to prevent stroke. Now, if you came to me and your blood pressure was 120/80, I would not put you on medicines to get it lower. But trial, observational data, millions of people observational data suggests that the lowest risk for stroke, specifically, since we're talking about stroke, but all of the vascular things, the lowest blood pressures have the lowest rates. Blood pressure is 100/50. 110/60. They have the lowest rates. So again, I'm not going to take your blood pressure from 130/70 and try to hit 100/50 with medicines, because you do tend to run into side effects of meds once your blood pressure gets that low. But clearly higher blood pressure is worse. 140s, 150s, 160s, okay? If you smoke, quit. Don't take up smoking if you don't already smoke. Surprisingly, people do that even later in life. And then, of course, get good sleep. Any questions about these things right here? Yes?
So just going back to the high blood pressure, for someone 65, that age group that's had a TIA before, what's just a good range for blood pressure?
I would aim for less than 130/80. 120s/70s or better would be great. Again, lowest that you can get. Most of the time with some of these other changes, a little bit of weight loss plus some sodium restriction, not complete sodium avoidance, that's impossible, but lowering the sodium. One of my favorite things to do in clinic is to ask people what they ate in the last day, because you get a lot of information from that, and usually most of them have high sodium diets without realizing it. One thing that I do also is I try to find the foods that they like to eat and use and go over the actual sodium content on the computer with them in the office. And one that just a regular example that I use is making a Publix sandwich. Everybody knows Publix, their subs are great, all this stuff. Publix subs are amazing. They're very high in sodium. If you have even a 6-inch Publix sub, you're looking at about 500 milligrams of sodium with a little bit of turkey, a little bit of cheese, just the bread is where all of it is. One slice of regular bread typically has 150 milligrams of sodium.
And what's the daily amount?
Most on the label it asks for 2,000. I personally, if you're eating a 2,000 milligram sodium diet, congratulations, you're like in the vast minority. The European guidelines recommend less than 3 grams or 3,000 milligrams. Ours are 2,000. I split the difference. I say 2,500. If you're doing 2,500 milligrams of sodium or less a day, you're probably doing a good job. But the other thing that you should be looking at is maybe just eat your regular diet and see how much sodium is in it. And it may surprise you, and it may, just reducing that sodium may knock 4, 5, 6 points off of the systolic blood pressure, the top number.
Yeah.
And that may be where you get a lot of your benefit from.
Back to blood pressure.
Yeah.
If your blood pressure tends to be just a little bit high, 130, maybe 145, and the bottom number is 50 or 60,
Becomes tough.
what does that mean?
So it means that you're normal aging. So as you get older, vascular biology causes, so for a long time, the top number and the bottom number kind of parallel. So if one goes up, the other goes up, if both go. But then as you get older, 70s, 80s, 90s, they start to diverge. And it has to do with stiffness of the arteries that is purely age related. So you could have had normal blood pressure forever, and then it starts creeping up and you start splitting. So instead of 120/80, you're 130/70, 140/60. It can be a challenge, okay? Most people are not overly symptomatic from the lower diastolic blood pressure, but it's hard. There's no way to really stop the lowering of the diastolic blood pressure or raise it without also raising the top number. So it's a tough clinical situation. It is. We do the best that we can.
So it's not good that
It's not
the range is like that.
right. It's not bad per se, but it becomes just challenging if it continues to go up. The numbers that you say are not overly concerning. Yes, it would be better if they were lower, but I think as long as all the other risk factors are pretty well controlled, it's still a fairly low risk for stroke type blood pressure problems.
Can you say something about cheese?
What do you want me to say about cheese? I love cheese. It's amazing.
I love cheese. I love all
And
kinds of
sodium.
cheese. But I'm trying to stay away from a lot of meats.
Yeah.
Okay? And so it's like, my thinking is that cheese is like a substitute for meat. But is it? I don't know if it is. And also, what, if I have a lot of cheese, what is the best kind of cheese?
I don't know the answer.
I don't mean, you know, labels of products.
Yeah.
You know, I just mean, you know, what the most healthy cheese, I guess.
Honestly, I don't know what the most healthy cheese is. I mean, cheese, so
I love cheese.
leaner and lower saturated fat cheeses would be the answer.
Such as.
Feta,
It's goat cheese.
feta and goat cheese. Mozzarella is okay.
Feta and goat,
Yeah, feta and goat cheese.
and mozzarella.
Yeah. So you're kind of getting to the most of the recommendations follow for diet. If you can kind of follow a Mediterranean style diet, and that's one of the reasons why. That's also very high in like olive oils and like healthier oils, fish and fresh fruits and vegetables. But yes, feta, goat, mozzarella are typically better. The really like delicious cheeses, Gouda, and
You love
right.
cheese, it's all over your face.
Oh man, it's great. It's great.
Swiss cheese.
The other thing that I would say is diets, eating and making changes. I hate even the term diet because diet is so loaded. The word diet is such a loaded term. Your eating habits have to work for you. So if cheese is important to you, it's less about like elimination of cheese and more about appropriate frequency and portions and things like that. So, you know, if you try to eliminate things that make you happy, you're gonna fail over time. You may do great for 2 or 3 weeks. We can all pretty much stop doing whatever it is that we like doing for a couple of weeks, but then you're gonna be miserable and you're gonna get tired of it. And then you may overindulge in those things when you go back to it. So it's finding a healthy balance of all that stuff.
That helps.
Getting rid of red meats and things like that are fine. Fish is great. Having a little bit of lean meats like pork or chicken or things like that occasionally are fine.
I recently had the opportunity to travel, and in that trip, we went to an herb market, and they were talking about all the benefits of hibiscus tea. So I get a bag, I come back and I research it. Well, hibiscus tea is like the miracle drink. It lowers your blood pressure, your cholesterol, your blood sugar. It helps your immune system. It just does all sorts of wonderful things. Now, are you familiar with?
Sounds great.
So I thought, you know, if this was so outstanding.
We should
the
make
doctors
a
would-
hibiscus tea company. And I can retire early. That'd
Well,
be
I
great.
thought you'd probably be recommending it.
Yeah. No, I think it is naive to believe that Western medicine that's practiced very aggressively in the United States with medicine, procedure, is the only way or the best way even to do health, to keep people healthy. So I have no problems with being open to the idea that does help. I do push back when I have patients who have had stroke or had TIA who want to only drink hibiscus tea or take turmeric or all of these other supplements and not take the clinical trial proven medications. And that's where I think, that's where you just have to feel trust in the person that you're talking to and have a conversation. And that's where I push back a little. My dad is a great example. My dad had a heart attack and really stopped taking a statin. And so I was like, I don't know if any of these supplements are gonna help you. I know that the statin does. I know that the statin in secondary prevention trials of a second heart attack significantly lower your risk of having another heart attack. And I can't tell you what these other things do. Do those things as long as they don't interact with your other medicines, but also do these things that we do have some evidence for. Okay, I think that's great. Yeah, there are all kinds of non-medication ways of addressing these problems. If you start running into doing them over and over and waiting years before initiating therapy when it looks like the risk factors aren't improving, then I think it's time to really be considering other things like medicine. Yeah.
How about a nutritionist?
Man, if you can find a bunch, that would be great. I think the biggest nutritionists are great. They're phenomenal. They're super helpful. There's not enough of them. Just like there's not enough cardiac rehab people, you know. So I think getting a referral to a nutritionist is always fine. I have generally reserved it for my people who have specific issues, like extremely high triglyceride levels that don't improve with cholesterol medicine. That's kind of a unique problem, and a lot of it can be addressed with diet. I know that our surgical weight loss clinic here has a lot of referrals to the nutrition folks. But yeah, I wish we could like multiply them. Yeah, I wish we could multiply them by 100. I mean, I would argue that they're a lot more important than most of the doctors that you go see. I'll just say that. You know, that this is the hardest part of what we do, and you know, most of us have such little time to really counsel on diet interventions, but it's where you can get a lot of bang for your buck. Yes.
Can we ask Emily to maybe start with one nutritionist able to let 100 people look at their Zoom? Everyone we know says nutrition is important. I'm sitting next to a woman that had 165 over 80 blood pressure that I'm taking to the freaking hospital. She's like, I'm not going on further. So she started doing Dr. Living Good and the beets and the checking it every day.
I open my refrigerator now, and I've got already baked sweet potatoes. I've got all my foods, you know, my beans already cooked, but all whole foods instead of what I was eating. And
so I just wondered if Emily,
and losing weight.
Oh yeah, we go to the pool every 6 days a week. Yeah, and it's just amazing what it can do to this 70-year-old body. But I was just wondering if maybe Emory would understand that if they could take one nutritionist and serve 150 people on that Zoom call, it might be nice.
I think that's a great point. What I would say, my counter to that, not as an Emory employee, but just knowing how hard nutrition is. Kind of going back to what I said, it's very individual.
Yeah.
It's extremely individual. So I wonder what the utility might be. I mean, we all know the big tent pole, you know, eat better, right? You know in theory what eat better is. It's doing it and like having a way that works for you, based on what you like to eat, what you can't live without, what is important to you culturally, what is important to you, what is capable of getting financially. Like, it's such a unique thing to each individual person. So I definitely hear the feedback. I'll run it up, but my guess is that the reason they don't do that as much is because of the very individual nature of
Because I did
nutrition.
a lot of research and stuff and find out what the sodium and everything. It was unbelievable. So I had
literacy. There's so much that goes into all of this stuff.
Blood type is a very big factor.
I don't know that. If you tell me.
From experience
Blood type.
with my wife. I spoke with someone some years ago, mentioned some of the ailments that she had. They suggested a book. We got the book, read it, and deleted chicken from her diet. And she realized after a few months that she didn't need to take any Flonase to
Oh,
free up her,
nice.
because there was an enzyme in the chicken and her blood type
Yeah.
that was causing the clogging.
I would say for sure, and I know we're running low on time, but I would say that nutrition science is hard. And I would also say, don't be skeptical necessarily of everything that you read. That sounds like an amazing thing that happened, but there's a lot of other stuff out there. People write books very quickly and easily and go on tours and stuff with very little, I won't even say it's science, little evidence
Research
behind it,
Yeah.
because it's hard to do. You can imagine, it's very hard to do a randomized control trial, which is the best, with diet and feeding people. You basically have to like lock them in a room and like watch them eat and give them, it's like mouse trial. I mean, you're basically trying to make mouse trials into human trials, which is not gonna work very well most of the time. It's very hard. Recall trials, I think I ate this yesterday, but I can't really remember. I forgot, I left out all the snacks that I had during the course of the day. It's just hard. I think from what I have read, I think things like the Mediterranean or the DASH diet is another one for hearts and vascular specific health. Not for anything else, but for those things are about as good as you're going to see. And those are very easily Googleable. There are plenty of books that are just like Mediterranean diet books that are endorsed by the American Heart Association as well. So, yeah.
Why is it that it's more common in women than men to have strokes?
I don't think that we know. I think that's just an observation. I think that, there's a lot of theories. Just like, there's a lot of theories about why after menopause, women have as many or more heart attacks as men, and a lot of it may have to do with the hormone differences pre and post menopause. I don't think we know why women have more stroke than men. But I think the important thing, and the reason I even say it, is because historically, we have done a very bad job of even considering women or people of color in any data and research that we do. And when you don't talk about it with people who aren't white men, I can say that because I'm a white man, then nobody else really knows about it. Nobody else thinks about it when they have their symptoms. It's anxiety, it's something weird going on in my arms, nothing, it's nothing. So I think probably some of it has to do with the increased recognition that these are problems that women also have. They're not immune to it. So some of it's probably just recognition and doing a better job of communicating. But I don't know, I don't have a good answer.
There have been other studies done, and proclamation from those studies with a certain group, and this is a religious group, the Adventists, and they have found that they are among some of the longest living people generally in that particular group. And I happen to have several family members who are Adventists, and some of them don't make it, but some of them, I've got 4 people in my family right now who are 90 and over.
Yeah.
And several in their 80s and 70s. Most of them Adventists.
Living the right.
They don't need
Right.
There you go.
Thank you so much, Dr. Thomas.